Tanse, Shegan, and hello everybody. I'm so very glad that you could all join us here today. We always appreciate when people join us on a Saturday. We know it might not be the best time, and I'd like to extend a warm welcome to our event, Decolonizing Medicine, Indigenous Perspectives on Gender and Health Equity. Of course, I will introduce myself. My name is Mcleod Bauer. I am a Métis man based in Treaty 6 territory, the homeland of the Cree and Métis nations. As well, I am the medical education project leader for Medical Herstory. To those who are familiar with our organization, welcome back. It's always fantastic to see returning faces. But to those who may not be familiar with us, I want to provide a brief introduction into the work that we do. Medical Herstory is an award-winning international nonprofit on a mission to eliminate sexism, shame, and stigma from healthcare experiences. Pursuant to these goals, we publish first-person illness narratives, facilitate interactive workshops with medical schools, and host educational events like this one. If you'd like to learn more about us, you can, of course, follow us at Medical Herstory across all of our social media platforms, or at medicalherstory.com for our website. With that out of the way, I will move on. I would like to acknowledge the land on which many of us are meeting today. Medical Herstory is based in Tiohtià:ke. Many of our events and operations are located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Kanien'kehá:ka of the Haudenosaunee Confederacy, the Huron-Wendat, Abenaki, and Anishinaabe nations. We recognize and respect these groups as the traditional stewards of the lands and waters on which many of us are today. Medical Herstory is an organization that is dedicated to advocating for patients, reducing barriers to accessing care, and eliminating internalized stigma. Thus, it is imperative that we acknowledge the roles that colonization, white supremacy, and medical racism have played and continue to play in our healthcare system. Through our projects, Medical Herstory is dedicated to the continued pursuit of truth and reconciliation. As well, I would like to issue a content warning for today's event. So the next slide. Topics of discussion today may include racism, sexism, trauma, colonization, genocide, medical violence, including forced sterilization, and other sensitive subjects. Medical Herstory recognizes the challenge of today's discussion, and we are extremely grateful for our speakers in sharing their knowledge and experiences. Of course, above all else, practice self-care and take breaks or log off if you need. Finally, I will round our introduction off with Zoom etiquette. So just in terms of points, please respect everyone during the meeting and on the chat. Please remain muted at all times unless you are speaking to minimize disturbances. Please direct any questions, including to speakers, to @IsabelConca via chat. She's indicated as a Medical Herstory volunteer member. This event, as you all heard the robotic voice say, is recorded, and closed captioning is available at the bottom. Finally, active listeners are joining us today. I believe Tori Ford will be our main active listener. So if you need any support, please message her and via the chat, and she can reach out and provide as much support as she can. With all of that out of the way, I will begin our storytelling segment. Our interactive event today is focused on Indigenous gender and health equity, helping to bring to light the pervasive failures of our healthcare system and the challenges that Indigenous peoples face across North America. Following the uncovering of the atrocities at Kamloops, Coesus, Brandon, among others, Medical Herstory postponed this event from its early date in early June to now. For us all, these stories invited anger, sadness, and mournful reflection. As we heal following this news, we believe it is critical to remember that these injustices are not remnants of the past. Indeed, as you will hear today, present-day inequities are kept alive by stigma and discrimination. As somebody from Saskatoon, I was shocked to read a review published in 2017 outlining the coerced sterilization of Indigenous women within the Saskatoon Health Region. It is in the spirit of truth and reconciliation that Medical Herstory has chosen to continue with this event. In terms of the structure, I will yield the stage in turn to 5 speakers whose work as healers, advocates, storytellers, and leaders has had profound impacts, after which we will open the floor to a panel discussion and open Q&A format. If you have any questions, as I noted earlier, please send them to Isabel Conca, and she will indicate when you may ask your question to the speakers, just to ensure that the flow is kept going. And with that out of the way, I would like to start off our storytelling segment with Dr. Veronica McKinney. Dr. Veronica McKinney is a Cree and Métis physician and the Director of Northern Medical Services at the University of Saskatchewan's College of Medicine. Dr. McKinney was inspired early by her great-grandmother's example as a traditional healer and midwife. Before pursuing medicine, her work has shaped medical curricula, supported Indigenous people in reconnecting with traditional modes of healing, and fought to dismantle the barriers and inequities which confront Northern Indigenous communities. With that, Dr. McKinney, the floor is yours. Thank you.
It's really great to be here, and thank you for the opportunity to come and share my stories. I have many stories. I guess one of the things that I think about immediately is just growing up as an Indigenous woman. Obviously, we see the inequities left, right, and center. I grew up here in Saskatoon. After a time, I did spend a lot of time up in the north. My family and community are from the northwest part of Saskatchewan, so I would spend my summers, a lot of my summers, in the north, fishing, gathering berries, all kinds of things that we would do to be able to have food for the winter kind of thing. But it was interesting, and growing up in a non-Indigenous environment, how I wasn't allowed, when I made friends with kids, how I wasn't allowed in their homes. All of a sudden I'd be, they'd hand me an ice cream cone or a chocolate bar to kind of get rid of me, kind of thing. And it's interesting because you still see that today with kids, how people don't want their kids interacting with our kids. And when I was in high school, the idea that I worked really hard, and I have always wanted to be a doctor. I guess it was my upbringing and the teachings that my mom had. My mom grew up with her grandmother, and so I learned a lot from her, not knowing at the time that how much value that was. But when I was in high school, even the fact that I had teachers that would literally say to me, like, you'll be lucky if you're here still at 16 because you're probably going to get pregnant. The assumptions, the stereotypes, they're no different today than what they were back in the day that I was going to high school or trying to make my life or my way through university. So I took the long and torturous route. I was a lab tech first, and then a nurse, and then a doctor. And I think a lot of that was trying to build confidence in myself to be able to make it into these systems. But I also think, as we've been taught from our way of being, is that things happen for a reason. So I've seen many perspectives and different angles of how things are done. And I guess some of the things that I've seen, particularly when I was training, was on the obstetrical ward and the stereotypes that were there. And even as a student, as a resident, I would advocate for our patients. Sometimes our patients had kids at home that they needed to make sure were safe, that they wanted to make sure that they were looked after. And somehow that was turned around to the dialogue about, well, if they were really sick, they would stay here. If they really needed to be here, they would be here. Like, no comprehension of what people had to go through. In working with the North, and I've worked in many Northern communities across Canada, but certainly in Northern Saskatchewan for quite some time now, we see that things like even having babies is so different in our communities compared to society in general. The access to care is really reduced for sure. A lot of our people, so in Northern Saskatchewan, we have greater than 85% of the population are Indigenous, which is actually higher than the Yukon. It's higher than the territories. It's even higher than Nunavut. And we have very little that speaks to that and the diversity of our communities. We're not all the same, of course. So many of our communities, 50% of the people in the North live on First Nations territories. And we know that despite the fact that, we often think of one healthcare system, the reality is there's two healthcare systems. One if you are Indigenous and one if you are not. In fact, I always think it's really kind of funny when you think about it that we carry a card. If you're a First Nation status person, and now even here in Saskatchewan as a Métis person, you carry a card to prove your race. They did that in Nazi Germany, and it was something called the Unpassed card. And they did that in South Africa under Bantu law. It was called the citizenship card. And yet here it's okay. We don't see it as a race-based issue, but yet really it is. And a lot of people who are non-Indigenous seem to think that this is, we get benefits with this. But the reality is it means that we have to access our healthcare through an entirely different system, the federal system versus the provincial system. And we know that the funding that's associated with that is much, much less. So what that translates to on the ground is that many of the community people, especially as women, coming into any kind of facility is very foreign for many of our people, for sure. Most of the care is delivered, if you're on First Nations, at a nursing station. There may be a nurse or a nurse practitioner available. Often the doctors that come in are kind of flying in and flying out. And they're different doctors. And even in our north right now, even if you're in a community where the doctors reside, the change in the way people are practicing is that they're not staying in communities. They don't live in the communities. They come and they go, and there's lots of different people providing the services. And that is very difficult on our community people, because one of the core things I really believe is so important is relationship. And it takes time to build relationship and time to build trust. We don't have trust in the system. There's a long history of medical hospitals and all kinds of disparities. So for many of the women in the North, when we do have women that are pregnant, the care is definitely, there's lots of research to show we don't get the amount of care that women do down south, or women that are non-Indigenous. But even such things as being able to access an ultrasound, which is often the first time that you get to see your baby. Many people want to have their partners with them. They want to share that with the family. Instead, they're sent down to a tertiary care center and have to be there alone, often traveling sometimes in these medical taxis where there's lots of people in the taxis that are sick. You have to go from appointment to appointment and sit and wait. And you can imagine being pregnant and not necessarily having food or drink or anything like that, and just trying to keep yourself safe and healthy amongst this situation. It's a very different perspective than it is for what we imagine and what we see other people having, for sure. When it is time to deliver babies, there's really only one site in our communities that delivers low-risk babies. The rest, all the people have to come down again to either a regional or a tertiary care center. And so again, it's a very different picture. And I've heard medical professionals describe it, oh, no worries, they get a plane ride, they go to a hotel, and then they come over here, almost as if it's like, I think they're imagining it's like they're a 5-star hotel with room service or something. Instead, they're often these places where there are, murders going on and lots of traffic, so people who are from up north are not used to hearing all those different sounds, and often the women can't sleep very well. It's not uncommon to have diabetes for many of our community people. So even having access to food and traditional foods that we normally would eat is not there. And so you're sitting in a hotel room waiting to go into labor. And then when you do go into labor, you go to a hospital, often again alone. It's only been recently that non-insured health benefits allow for a partner or somebody to come, a support person to come with you. Often your kids are at home, so you wonder, how are your little kids doing? And you've never been away from them for that long before. So it's difficult. And then, as you mentioned, Nick, at the beginning of the talk here, we've seen many of the women, not only from the north, but even in the inner city. I also practice in the inner city in Saskatoon. And we see that many of the women are coerced into sterilization. And, it's sort of described on the practitioner side as, well, we don't want people to have to come back. We want to make sure that everything's done up right. And, they've already had X number of babies. How many babies do they need? And it's a lot of judgment, a lot of stereotype. When we read Mary Ellen Trapel-Lafond's paper on racism in healthcare for Indigenous peoples in BC, some of the stereotypes were around how we're bad parents, how we are very promiscuous, that we don't, there's a lot of these associations that are associated with being an Indigenous woman. Many of the women that I work with experience violence as well. So the idea of trust is not there. And when you are experiencing this, idea of coercion, many of our people, even to this day, at that vulnerable time when you're having a baby and your body is doing a lot of different things, It's a beautiful time, but unfortunately, I think for many of our women, it is not the beautiful time that it should be, and that they're deprived of that. And then what's thrown at them is that they should have things done so they can't have any more babies. So when that was happening, we actually had a patient complain to at the time it was the Saskatoon Health Region, and they came and they asked me, like, what do you, one of the things they decided to do was, I give them a lot of credit because they did decide to actually follow this up, because the other problem that we see is when people make complaints, often there is no follow-up. So they did get Dr. Judy Bartlett as a Métis physician out of Manitoba, who I know quite well, and Yvonne Boyer, who is a senator actually currently, but was a nurse originally and then a lawyer. And they conducted the review and the report. And what they found was, in fact, there was coercion. There were women that came forward. And even at that, it was difficult to convince women to come forward to actually tell about their experiences. But they did. And subsequently, there was a study done across the country that showed that this is not unusual here in Saskatchewan. It is common throughout Canada. And when you look back, we had things like Indian hospitals as well. These experiences are really no different today than what they were back in those days, despite the fact that we're supposed to have this universal health care and equal health for all. We don't have equal health for all. So, and then I throw in as well, I have a number of transgender patients. We have many transgender patients all throughout our communities. And it's really sad to see that the treatment that many of our Indigenous transgender people in particular experience is horrific. So, and even having access to hormone therapy is very limited for many people. So I can give you a number of different examples of how this plays out. The other thing I would say is we also have to keep in mind when we think about all this, that all these babies, all the people, all the kids are affected. A lot of these women have what we call adverse childhood events, where they've been exposed to various forms of abuse and trauma. And we know that the more of that you're exposed to, even in the prenatal stage, the more likely it is that your life expectancy is reduced. The more likely it is you have, chronic disease, even cancer, things that even a higher number of broken bones. So we can show this. And I think another concept that I just wanted to bring forward was this idea of DARVO, where when you do bring this forward, DARVO stands for deny, attack, and reverse the victim and the offender. And we see that commonly, again, when there are reports within the healthcare system where the person who is the perpetrator denies the behavior. They then attack the individual who's doing the confronting, and then they reverse the roles of victim and offender. And I see this time again. In fact, our systems currently support the perpetrators. So because they're healthcare providers, there is a system that allows them to be protected, wherein they often don't even have to come in and hear what the complaint is or account for what they're doing, and there are no changes to the system whatsoever. So there's a lot that we need to do. The other thing that I would say is, despite all of this, we are matriarchal communities. And if you want to go to any community, the pillars of those communities to this day are women. There are kokums, there are aunties. So the resilience is there, the knowledge is there. We are the medicine for each other. Our traditional ways are the ways that help to protect us. And more we see that. And again, there's lots of research on that. The stronger you are in your culture, the healthier you are. So we know our ways help and protect, and they are the ways that will lead us through on into the future. So I will leave it at that, because I think I took way more than 10 minutes. But anyways, lots of stories, like I said, and lots to be talked about. And I can't wait to hear what the other ladies are going to present today as well. So thank you for having me.
Thank you so much, Dr. Veronica McKinney, for your insights and your stories. I'm also based in Saskatchewan, and the research I do into preterm labor looks at how Indigenous women oftentimes, because there aren't other methods to predict it, have to be removed from their communities for potentially half of their pregnancy in a foreign place with a foreign community, away from their culture, away from their support network. And that's resounding across the province. And those are unacceptable precedents. Your insights also into the two-tiered healthcare system and DARVO are foundational, and I would definitely like to follow up on those, and I will over email. With Dr. McKinney's speech away, I will move on to our next speaker, who will be Dr. Karen Stott. Dr. Stott is an assistant professor of the Women and Gender Studies program at Wilfrid Laurier University. Her teaching focuses on Indigenous settler history, feminism, and the politics of decolonization, and issues of reproductive and environmental justice. She is also the author of An Act of Genocide, Colonialism and the Sterilization of Aboriginal Women in Canada. It's very interesting to see some of the medical points that Dr. McKinney brought up and how they'll be contextualized into Dr. Stott's work. So please, Dr. Stott, take it away.
Thanks for having me. I don't know, I'm happy to be here and thank you for inviting me to this panel. I don't know what I have to offer after following Veronica and all that she's offered, but I'm happy to talk a little bit about my research on the course sterilization of Indigenous women in Canada. I'm a settler of Irish, Scottish, English descent. I'm non-Indigenous, but my work came out of my relationships with Indigenous people, and Indigenous people always told me that course sterilization is something that happened in their communities, and there was very literally nothing to read on the subject. And so that's what my work came out of an attempt to be accountable and useful to the people that I care about. And so I spend a lot of time in the archives. I do archival research. That's changing a little bit now, but particularly looking at the words of government officials in health and welfare in particular, how they speak about Indigenous people and how those conversations and the factors surrounding those conversations inform Indigenous people's experiences of healthcare. And I'm particularly focused on course sterilization, which unfortunately has a really long history here in Canada and elsewhere. And just for a little bit of background, we know Indigenous women were sterilized in Alberta and British Columbia under what's often referred to as eugenic legislation from the 1930s to the 1970s. In Alberta, for example, Indigenous people were about 2 to 3% of the population. They were about 6 to 8% of those sterilized overall. But in those later years, in the 1970s, they were about 25% of those sterilized. And my research has really looked at how the practice has impacted Indigenous people outside of eugenic legislation. So the archival files that I looked at document about 1,200 Indigenous women, just under 1,200 if you only include Indigenous women, just over 1,200 if you include Indigenous men as well, who were sterilized from the late 1960s to the early 1970s, including in federally operated quote unquote Indian hospitals in Canada. And the documents I looked at, they don't tell whether all these sterilizations were necessarily coercive, but they do tell of consistent problems with informed consent. There were often language barriers and interpreters weren't always used. And they consistently show a racism and a paternalism by health professionals and government officials in talking about Indigenous people and talking about sterilization as being for Indigenous women's own good, as Veronica mentioned as well, as a means of combating poverty in Indigenous communities. And so since the first part of my research came out in 2015, there's been over 100 Indigenous women who've come forward with their own experiences of coerced sterilization, spanning from the 1970s up until as recently. I think the last one on the record, so to speak, is from December 2018. And many of these women experienced coercion when they were in the hospital giving birth. And as Veronica mentioned, Yvonne Bauer and Judith Bartlett's a report from 2017 documenting some of these women's experiences. And in speaking to those women, they found that all of the women that they spoke to were either coerced, they felt coerced, or they felt an attempt to be coerced into sterilization through pressure from doctors, nurses, and sometimes social workers. And importantly, they point to systemic racism in healthcare, which is linked to colonialism as a big part of Indigenous people's experiences. There's currently proposed class action lawsuits in Saskatchewan, Manitoba, Alberta, and British Columbia. But women have come forward from nearly all provinces and territories across Canada. And we know not all those who experience violence are willing to come forward. And so my research has quickly refocused on trying to better understand the context in which these more recent experiences of coercion are taking place. And so I'm focusing on family planning policy and practices since the 1970s. So since birth control was decriminalized in the criminal code in 1969, and sterilization consequently became more accessible as a reproductive option. So I'm seeking to better understand how this has shaped Indigenous women's experiences. And I'm finding there's been a consistent trend of approaching Indigenous reproduction as something needing to be curbed. And again, this is based on archival research at the Federal Archives, but also I've been doing a fair bit of archival research in Saskatchewan as well. In particular, a focus on young and single Indigenous mothers. And the idea coming across in the words of officials is that coerced sterilization is useful to address poverty, but also other social problems, whether it's high infant mortality rates or the purportedly high rates of fetal alcohol syndrome in Indigenous children. This is something that's been coming up in the archival records. And this was particularly, became the case as more Indigenous people moved from reserve or remote settlements into urban centers, where many provincial officials considered Indigenous people as a strain on provincial budgets, to be blunt. That's what these are. I'm still parsing together that history, but these are some of the themes that are coming out there. And so all these things contribute to reproductive options being presented in ways that can result in coerced sterilization. But I think, and as I've mentioned before, and Veronica has been touching on as well, it's important to understand coerced sterilization. It's only one of many forms of violence that Indigenous women and their peoples experience under colonialism. So whether that's residential schools, the 60s scoop, the high number of Indigenous children that continue to be removed from their communities, the practice of birth alerts, so Indigenous women having birth alerts on their files and having their children removed immediately after birth. The large number of women who can continue to experience violence or who are criminalized or incarcerated. If you look at the incarceration rates in Canada and who is taking up space in our prisons, it's disproportionately Indigenous women and Indigenous men. But also the many environmental injustices that Indigenous people experience that come from exploiting Indigenous lands and resources. And part of, and I hope Patsy Cook is on this panel as well, because I've learned a lot from her and I teach her in my classes, the importance of connecting violence against the land to violence against Indigenous bodies. That there's actually a failure to respect Indigenous women and their bodies or their reproductive sovereignty, so to speak. And that is connected to our failure to respect Indigenous lands. There's often no consent for either here in a Canadian context and also elsewhere. And so I think if anything, and I spend most of my time speaking to non-Indigenous people, if anything, people are most able to recognize that coerced sterilization is a violation of a right to make decisions about your own body. And some of those who have been coercively sterilized have said that they didn't know that they had a right to decide what happened to their bodies. And even when they vocalized or practiced or exercised this right, they weren't listened to by healthcare providers. But coerced sterilization also has other implications when we're talking about Indigenous people. It breaks the connection between one generation and the next by removing Indigenous women's ability to reproduce, but also in preventing reproduction, you're preventing the ability to pass on culture and to pass on connections to lands. And so in that sense, in my book, I argue that it terminates the legal line of descendants who have connections to Indigenous lands, or that we as Canadians have obligations to. And that's always been a goal of Indian policy and many of the policies and practices that have been imposed on Indigenous people. And so it's important to recognize that for Indigenous people, this has larger implications, hence why my book was called An Act of Genocide, because to impose measures to prevent births on members of a group when it's done to undermine their ability to continue to exist. There's a name for that in international and now Canadian law, and it constitutes genocide. And I actually spend a fair bit of time in my book talking about all of the time and energy Canada has put towards attempting to avoid that charge or limit the definition of genocide in Canadian law. And so since 2015, we've seen the Senate, the House of Commons study the issue. The Senate is continuing to work on the issue. Prime Minister Trudeau acknowledged forced sterilization as a serious violation of human rights. Internationally, the UN Committee Against Torture concluded that forced sterilization is tantamount to torture, and they've called on Canada to act. And the inquiry into the large number of missing and murdered Indigenous women and girls included the issue in their final report, and they've stated clearly that the treatment of Indigenous women constitutes genocide. And even though he didn't initially, Prime Minister Trudeau did eventually accept the report's conclusions. And now we're having panels like this where forced sterilization is being talked about more openly, even though I would say Indigenous people have been talking about this for a very long time. It's just that non-Indigenous people have not always been paying attention or listening. So with that in mind, I just want to end by offering a few thoughts on this is a panel on decolonizing medicine, so to speak. And I want to preface that by saying that I obviously don't speak for Indigenous people, but my thoughts here have definitely been influenced by them. And I think we need to think about those who've experienced forced sterilization and what they need in terms of adequate supports and reparations for what's happened to them, and how this form of violence continues to impact them every day. People don't often recognize that there are continuing impacts, whether they're psychological or physiological impacts to being sterilized, especially without your consent. I was speaking with one woman a couple days ago about coming on this panel, and I asked her what, if anything, she wanted me to pass on to you. And she said, until forced sterilization is explicitly criminalized and people are held accountable, women will continue to be at risk. And she said, until healthcare professionals hold each other accountable, we'll never be able to deal with racism in healthcare. When you see something, do something, she said. Call each other out, talk to each other. We can't do anything about racism without holding each other accountable. And so that comes from one woman who has experienced that form of reproductive violence. So addressing systemic racism in healthcare is important. Healthcare professionals, particularly non-Indigenous, and that's who I'm talking to here, is non-Indigenous healthcare professionals, need to know about the history of colonialism and how it continues today. Need to learn about racism, about our lack of respect for treaties and Indigenous sovereignty, about poverty and stereotypes and that we might hold, and how that impacts not only the health status of Indigenous people, but how they're treated within the healthcare system. And we need to have a better understanding of how Western medicine itself as an institution and Western medical practitioners are not actually neutral or inherently good. That Western medicine has a very long history of being imposed on Indigenous peoples, and Western medical practitioners have played a role in perpetuating colonialism. And so thinking about that, but also thinking beyond Western medicine, as Veronica's indicated, we need to uphold our obligations to respect and financially support Indigenous people in reconstituting their own ways of health and healing, including Indigenous practices around birth, so that Indigenous people can freely choose between Western and Indigenous practices. And we need to make sure that Indigenous people have healthy environments to live and raise their children in, which means we need to start respecting Indigenous land. And if we think of that connection between the lack of respect for Indigenous lands as being connected to our lack of respect for Indigenous bodies, it becomes really important for Canadians to start living up to treaties and to the many other responsibilities that come from living on these lands. And so the question becomes for me, how do we, no matter who we are, there's 39 people in this room, right? How do we take up our responsibilities in our own ways by questioning our way of living and how it depends on violence against the land and other forms of life, and how it depends on violence against Indigenous people? And how do we pressure governments, corporations, and also the institutions that we all work within to do the same? And so I think this is something all non-Indigenous people need to start thinking about more intentionally in relationship with Indigenous people. So I think I'll end there. Thanks very much for listening, and I look forward to the next speakers.
Dr. Stott, thank you so much. I think at the beginning we noted that medical herstory deeply values the transformative power of storytelling. And I'd like to thank you in that context, that the stories that you tell, both of your own and others through your academic work, is helping to affect positive change. So sincerely, thank you. I also noticed that Perry Mcleod has joined us. And so we will move on to his speech. I will note as well, and I'm sure we'll all see soon, he did indicate that he is joining from an event. And so we might have problems with connectivity, but we will play it by ear. And so for his introduction, of course, Perry Mcleod Shabojezik of the Crane Clan is an Ojibwe Anishinaabe from Nipissing First Nation and the manager of cultural services for the Ninjan Sinanic Child and Family Services. Perry's spirit name is Anzuket, which means storyteller in his language. He is a recognized helper assisting in facilitating traditional activities such as pipe ceremonies, medicine wheel teachings, and harvesting game and wild medicines. Welcome, Perry, and please feel free to unmute and speak. Thank you.
Bonjour, Ani, everyone. That was a beautiful introduction. As you can see, I'm not dressed as nice as my picture, but as was shared, I'm at a gathering here in Henvey Inlet First Nation, and it's a family gathering of families from the agency that I work for, Ninjan Sinanic, and so we are enjoying our one of the first returns back to land-based activities. With COVID happening, we've been kind of pushed away from our mother for a little bit, but we've been planning and now are returning back to celebrating life as we know it, back on our mother's breast and enjoying that time with her. Just to share a little bit about how I've come to understand Indigenous or Anishinaabe medicine, health, living that B'modsuin, Mino B'modsuin, which is that good life, and how it relates to our medicine. And when I look at Western and traditional medicine, there are definitely differences in approaches, but I have to say that the origins of all medicines, all paths of medicines, all come from our mother. Our medicine, the Indigenous medicine, and our worldview on health and healing is more traditional in the sense that it has stayed close to our mother. Western medicine has tended to move away, further away from our mother in terms of the development of different vaccines or different medicines, different medical procedures and whatnot. But its origin is the same as ours. And so, I always look at that as what connects us, what connects all different medical practitioners in the world, is that we all come from that same fire. Some of us just have moved further away. For Anishinaabe medicine, we look at creation as our family. And I say that in that I mean that the plant beings, the animal beings, the elements, all parts of creation are part of our family, our creation family. We are all related. We are all connected. We share many, many things. And so it is that collective sharing where we are able to have a good life, a balanced life, that our health is well balanced if we stay close to our mother, if we stay close to that natural world and the natural medicines that our mother offers us in the different cycles that happen throughout the seasons. For us, it's that connection that keeps us in good health, that daily life, going out for a walk in the fresh air, drinking the teas that are abundant at particular times of the season, because in staying close to our mother, we are able to maintain a better health. And that also includes our spiritual, our mental, our emotional, not just our physical. So ceremonies become an important part of that. Our social relationships with one another, feeding our mind, feeding our knowledge bundles that we carry. So we live and we learn, and through that experience, we're able to share what we learn. So, you know, when we look at health, it's something that is a very holistic process and a very natural one. Western tends to divide things up into segments and focuses on each segment, whereas Indigenous medicine, Anishinaabe, Mshkike, that's what we call Anishinaabe medicine, is more holistic, where everything is connected to each other part of our wellness. And so each day we try to, in the best way we can, try to keep those connections, try to address each part of our beings. You know, we get up in the morning, we might offer our tobacco, maybe do a little smudge with some medicine, look at our food, have our teas in the morning that are abundant at that particular time of the year, eat good food if we can afford it or have access to it. Those kinds of things, and spend time with one another, sharing our day with our family, our friends, learning things each day so that we can use what we learn to pass on to our children or others who are looking for that knowledge. When we look at the natural world, we also see a kind of a mirror in that when we look at plants, for instance, plants are like us. We don't look at them as things, as just a product. We look at them as beings. Plants have families. They have their young that they have when they seed, and those young ones that grow around them. They have family, cousins. You know, the mint family, for instance, there's many mints, different kinds of mints. They're all related, but they are part of that mint family. They have friends. When we look at the blueberry likes to hang out with juniper, with jack pine, with bearberry. They are not related, but they like to hang together, just like us. We have our circle of friends that we like to be with, that we are drawn to. They move. They may move different from us, but you can see a patch moving from season to season, growing and moving in different places. So all plant beings, they move as well. They even speak to us. They have their own language, and I say that by how they show us things, and they communicate with us by showing us. For instance, when you look at the strawberry is, in our language, is called a heartberry because it looks like a heart. And so the heart, that berry, that strawberry, when you make that a part of your diet, it helps your heart. So that plant is telling us, I am good for your heart. So, and when I come up, I give myself to you. And if you accept me in a good way, don't just take me, but accept me in a good way, then I will help you. Plant beings, whether, you know, we use them for different medicines, are here to help us. That's all they do. They help us. They don't cure us. That's up to us. We are our own healers by our behavior, by the way we live our lives, the choices we make. The plant beings are here to help us, and they will offer their medicine to help us on our path. But we have to do the heavy lifting. We are the ones who have to do that work to maintain our good health. But our plant beings, the animal beings, the elements, all these things around us are here to help us with that journey. And so we look at things in that way, in a traditional way. You know, when an elder in a prayer or in an invocation at the end says, all my relations, they're not talking just about the human family. They are talking about everything, all of my relations. We recognize we are connected by so many things to each other, the elements, the animals, the plants, you know, everything is, we are all connected. And so in order to maintain that health, I come back to that original comment I made, that it's so that I'm going to end it there and just say that Chimigwech, thank you so much for allowing me to be a part of this conversation, and just to remind you that as Indigenous people, we have so much to share, and all we ask is that we be heard. and even a little bit of understanding in what we say. So, Chimigwech.
Thank you so much, Perry Mcleod Jessic, for sharing some insights into traditional modes of healing and what medicine might look like in a decolonized way. I would like to also extend a very happy thank you to all of our speakers today. Dr. Holly Graham and Kathy Cook, I have had troubles connecting, and so we were just briefly in contact with them. We'll still try to connect them. But in the meantime, what we'll do is open up questions from the audience, as well as some panel questions which we have pre-prepared. But of course, we'll yield to the audience first and then go ahead with panel questions if there aren't any questions from the audience. And so Isabel, if you want to take it from here.
Yes, hi everyone, and thank you once again to all of our speakers. I haven't received any questions yet, so I will give the audience a couple minutes to see if they send any. But in the meantime, I will go ahead and just start us off with one of the questions that we've prepared. So the first one is, and this is for all the speakers, feel free to answer. How do you think that we can promote Indigenous understanding among medical students and healthcare professionals to improve the quality of physical and mental care for the Indigenous community?
I don't know if anybody else wants to answer as well, but I think the beginning of it is to understand the underpinnings of colonialism, the idea of racism and oppression, and how it is so embedded in our current systems today. I think it's really hard for people to understand that. And I think, like I said, the dialogue or the stereotype is that as Indigenous people, we're a burden on society, that we're not contributing, that we get more than, all of these stereotypes that are just so far from the actual truth. And you know, Karen spoke to some of these, how much, you know, these efforts that even to this day are being spent on avoiding these things, you know, certainly in terms of the core sterilization, but also in terms of our First Nations children. You know, there's been cases that the court has found in favor of the Indigenous children, and still it's being, you know, taken to the Supreme Court, and all of these efforts and money in that area. And one wonders why, you know, even just taking that time and effort spent to learning about these pieces, I think would have gone a lot further than what we're seeing currently.
I don't want to take up space, but I was having a conversation with my sister who's visiting before coming on this panel today, and she was asking me about what I was talking about and how something like this can happen, right? And I don't really have an explanation. We can talk about colonialism and the need to exploit Indigenous lands, and we can talk about government policy, but at the end of the day, it's human beings in a room together, and it's some human beings treating other people. And I'm like, there's a really long history of non-Indigenous people not recognizing Indigenous people's humanity. So we can complicate it, and we do need to complicate it, but it is also such a simple thing that it comes down to. If you see somebody else as a human being, then you treat them as you want to be treated, right? And I think that's something, because doctors are people too, right? If you need to be reminded of that, we exist outside of the professions that we perform in. And what is it going to take for us to see each other as human beings? Because we, at the end of the day, that is what is going to create the change. Anyway, yeah.
Thank you for that insight, Karen Stott. If I may just add one thing, on your talk earlier, you spoke about how it's keeping or holding other people accountable. And oftentimes what we see, at least in medicine, is it becomes this old boys club, where these people are situated for perhaps decades in their ways. And so your comments of recognizing the common humanity of both patients and doctors is so important. And for future healthcare providers, recognizing that you are human, that you cannot play God. It's in the Hippocratic Oath. So remember those words. Perry, do you have any final comments on this question? It's in the chat if you'd also like to reference. perhaps not. He may be busy with his event. And with that, Isabel, I think we can move on to the next question.
For sure, thanks, Nick. The next question we have is, how can clinical settings such as hospitals, outpatient centers, community clinics best support Indigenous traditional methods of healing? And also, how can these traditional methods of healing can be supported at institutions or at a policy level?
Well, I guess I'll be brave and start again. So clinical settings, I think, you know, I think we have to consider even how things are, what they look like, or all these different things. I do have patients, for instance, who have a really hard time even walking by some of the hospitals because they look, for all intents and purposes, the same brick and mortar that the residential schools did, that they were so badly treated. You know, so I think trying to have things in a way that is welcoming to people. And I think, you know, sometimes, again, if we look at things even simplistically, like within, you know, our waiting rooms, we try to have like, you know, posters that reflect Indigenous people or art that comes from our community, or, you know, just recognizing that people come in often with families and babies. So we have things available for families, like, you know, for the kids or for, you know, moms, or we often, even in my inner city clinic, we often even have coffee. Normally we do, like right now with COVID, it's been a little bit more challenging. And we used to have, we are still serving, but just an individual couplets or cups, I guess, but things on like it could be fruit, or it could be, you know, soup, or those types of things, just to make sure that people feel welcome and such. I know that what I really do is I work at making sure that people do feel comfortable. And I often, when I teach about this, I tell people it's the same as when you welcome somebody into your home, or when you're going to somebody else's home, which is often the case I try to portray when we are going to the north. We're going to somebody's home. You're not going to go in there and start, you know, oh, this is how you do it. This is how you make the coffee. Oh, you've really organized your cupboard completely wrong. I mean, that might be, you know, your worst nightmare as a mother-in-law, maybe, I don't know. But, you know, when you think about it and you break it down in those simplistic ways, a lot of what we do to begin with is just establishing the relationship and figuring out not only what is going on with the person or people in front of us, but what's going on inside of us. What are we bringing to the table? What are our beliefs? What are our experiences so far? And how is that, you know, affecting what we're doing? And it's an interesting thing, I think, for many people who go into healthcare, because we often think, well, we want to help people and we think about what we're doing for others. But my experience has been that the more you try to do for others, the more you're actually learning about yourself. So it's kind of a weird reverse thing, I think, in lots of ways. But I think we have to really reflect on that as well, too. I think in terms of you know, one of the things I've talked about with some of my Indigenous colleagues, we call ourselves the grassroots Indigenous physicians, because we are both people that practice our traditional ways as well as, you know, physicians in the Western sense, that, you know, the idea of working together with traditional people is the best way that we can do things. We know that we operate a bit differently. I grew up in very traditional ways, and our traditional ways, by the way, is not just medicines per se. A lot of people think it's like the plants and the herbs. That's a piece of it. But our larger part is about how we live our lives every day. It's ceremony, it's connection to land, it's connection to one another. It's, you know, how we are, you know, the different processes that we follow. So there's so much more, and it's so broad that, you know, it's not just about taking something and then that fixes you. That's a very Western way of thinking of things, in my opinion. So I think that idea of how everything is affected. But I also think the idea of, instead of, you know, again, the way that we teach medicine is that it's about individual choice. Even in terms of health promotion, we say, well, did you exercise? Did you eat well? Did you do this? Did you do that? But it's almost as if you always have the choice. And we're learning more and more that a lot of these things, again, are more to do with systems and less with individuals. And so that, the assumption that everybody has access to good food is a huge assumption that is completely wrong. What about housing and the effects of housing? That's huge as well. So all of these pieces, and it's so much more than social determinants. There's a lot more to it. So I do think, the fact that we expect people to come into our hospitals or into our clinics is another way that we have of, thinking that it's an individual choice. We need to be going out more into the community and learning from our community and listening. One of the teachings I was often given was that we have 2 ears and 1 mouth. I'm not practicing that, obviously. I'm speaking a lot, but we need to listen twice as hard as we actually spend speaking, because it's through that learning from the people that we really know what's best, or how we can best support them in getting what they need, for sure. So I'll leave it at that, for sure.
Thank you so much, Dr. McKinney. Your point on medical mistrust brought me back to Yvonne Boyer's external review. And in, I believe, one of the first sections, she notes that, of course, through coercive sterilization, which you're robbing Indigenous women of is the reproductive capacity. There's no question there. But secondly, you're robbing them of their trust. And even though there might be very straightforward, common solutions to the problems that they may face, they aren't going to seek help for it. And medical mistrust becomes this dangerous thing that, how do we combat that? So thank you so much for your comments. I saw as well that at the beginning of the question, Perry Mcleod unmuted. So I'll provide the space here if he wants to maybe add on to the question.
Yeah, I've been listening, and both questions actually, but they kind of relate. But what she said, I mean, she hit it as far as my understanding. She hit the nail on the head. It's creating those spaces that are conducive to healing, and by dominating a space is not doing that. And oftentimes Western tends to do that, tends to tell you what you should be doing, not asking how you're feeling or how you think you can help your own balance. And so she made a number of points that I totally agree with. It's like creating that space. In our communities, we have a tradition. I think most of our communities do, of just sitting down and having tea. Coming in, visiting, and you go into someone's home, you're invited in, they offer you tea, you sit down and you visit. And that atmosphere is a beautiful space. And that's in a sense what that type of environment is something that would be conducive for anyone, not just Anishinaabe, not just Indigenous, but all people. We're human beings, and I think that sometimes, over that journey of Western medicine, that journey has brought doctors further away from that humanness, and it's about coming back to that and having trust in one another, trusting that there's magic in Western medicine, but there's also magic in Indigenous medicine. There's mystery in that, and part of that mystery is where the healing happens. So Western tends to want to pick everything apart to understand it, and there's a certain amount of that you need to do. But traditional medicine tends to, why do that? Because you're taking away the magic when you do too much of that. And just embrace that mystery and know that it works, and be content with that. But there is that urge for Western practitioners to delve and go as far as you can in anything. There's a teaching about how each of the colors of the human race have different gifts, and one of the gifts, two of the gifts that the European descendants have is the gift of travel and curiosity. I want to go to the moon. I want to go to the top of that mountain. I want to go to the bottom of that ocean. I want to see what's there. I want to travel into this frog in the laboratory and see what makes it, tick, what gives it life. How does it work? All those things. There's that, and that's not a bad thing. It's just like anything, balance, balance. And I think understanding that perspective, even having trust that Indigenous perspectives on medicine has value, has equal value. That kind of thing, I think, is important, and bringing traditional people who are knowledge keepers and practitioners of medicine into those institutions. I do some work at NAWSM here in Sudbury. Been doing it for a number of years. I go into the class with students and I share what I know, which is not a lot, but I share what I know with students to give them that other perspective. And so that process of being in those environments to share the knowledge and to find the connections, but also show the differences as well in both those perspectives. One of my teachers, Ronnie Walkagijikbo, he's passed away now. He was a CHR, but he was also a medical practitioner, and he used both Western and traditional medicine in his practice. And he said, he said something to me that really stuck. He said, there was a time when on Turtle Island, we only needed Anishinaabe medicine, Indian medicine. But now that we're open to the world, where we have diseases and things that are coming from other places in the world, then if that is the case, then maybe the cure or part of it comes from that part of the world too. So we have to be open to that and look at that, not to isolate ourselves, because today you open the fridge and you're opening yourself up to the world. We have kiwi, we have oranges, all these different fruit or medicines. That's medicine as well, the food we eat from all over the world. So if there are imbalances that come from those parts of the world, then returning to the balance maybe comes, or at least part of it, the answer might come from that part of the world as well. I don't know if that relates to the conversation, but that's where I rambled to.
That's a fantastic point, sir. Just the notion, it's often construed as Western versus alternative. And what I'm hearing from you is that it should be Western and alternative together, not an us versus them mentality, but together. Whereas traditional healthcare systems are only prioritizing one. And so that balanced approach is definitely something I think we can all learn from and consider in healthcare practice.
Yeah, and everyone's balance is different. One person might want more traditional, maybe more Western, or balances within those. Everyone, and it's to find what balance works for you. We're all individuals. We all react differently to the different foods and medicines and imbalances. So it's finding what works for each of us.
That notion resounds with birth, for instance. You can have traditional birth, but in terms of a preterm labor where additional intervention is needed, you may want that formalized intensive care in a hospital. So it's also circumstance-based. Thank you for your insights. Dr. Stott, do you have any points on this question, or are we safe to move to the next?
I appreciate their answers. I'm good.
Awesome. Well, in that case, Isabel, we will go to our third question. I believe actually Claire will be issuing it.
Yes, but actually Tori had a question in the chat. So Tori, if you'd like to ask.
Oh, sure, I can read it. Yeah, I want to know, what role do you all think that storytelling plays in decolonizing medicine? It's been touched on a bit. I think it's an interesting point.
If I can share my thoughts on storytelling, I think storytelling is a vehicle for not only history, but teachings, knowledge. It allows the viewer, or the listener, to journey to a place through that story as an individual, because in our stories, I find that, I hear a story from one of my teachers, and it brings me, and I learn different things from that story. Someone else might hear the story and come to a different understanding of the story or the different things in that story. But the stories have these gifts inside them. And, our words have medicine in them. How we speak to one another affects us. I can have harsh words for someone and they will receive it in that way, or I can use kind words and they will also receive it in that way. And our stories are full of that medicine, the knowledge, the way that the stories are told. I love a good storyteller. you know, who takes you into that story, who pulls you in with their words and how they say them. Stories, I think, are really important at so many levels, you know, and each person who tells stories has their way of telling them. And I always say that when I tell a story, I'll share a story and then I'll say, me, have to sound like me, sound like yourself, take that story and embrace it, let it become yours. And there are spirits in stories because there's energy, there's knowledge, there's things in there that we receive. You know, use that, share that, embrace it, take it in, but also share it with others. So to me, storytelling, and I'm a little biased because that's my name, Enzo Kid, storyteller, but I've come to understand just we go on computer, we're on our phones, you know, from really think, you know, it's good, but I think it's also important that we continue the practice of storytelling.
Thank you so much for those comments. The connection went in and out a little bit, but I think we all got your points. Learning about storytelling from the master himself. Dr. McKinney or Stott, do you have any comments on this question?
I defer to the storytellers, or I don't necessarily consider myself a storyteller, even though I've been told that I am. But I think stories are powerful to get us to pay attention to people's voices. Right, there's a lot of people, from my own perspective, right, is where I'm coming from. A lot of people have been telling stories for a very long time and they have not been listened to. And so I see my role not necessarily as the storyteller, but as trying to create space to magnify those voices. So, but I defer to the storytellers to speak more about that.
Yeah, I was going to say, yeah, I mean, you know, I agree. It's interesting because in medicine now they talk about narrative medicine. That's really what they're talking about, is telling the stories, right? And I think the reality is you can have little odds and sods of information or pieces, but until you really join it all together as to what does that look like and what does it feel like, that's where we get back to the humanity. That's where we talk about the human, the person, you know, what does this mean really? How does that transcribe? And you know, I think too, the other reality is, like for myself, but I think for many others, we remember the stories. Those stories are what teach us. They help guide us. And they're also ways that we can teach our children and teach, you know, our colleagues, or, you know, and find different ways of looking at it, you know, as was already said. So to me, it's a way of putting things all together, and it's a way of learning, and it's a way of connecting with one another and seeing aspects or perspectives that we might not see if we didn't put it all together.
Emboldening the value of narrative medicine is quite literally the namesake of medical herstory. So thank you for your point. I think with that, we can defer to Claire for our final panel question. Claire, if you want to take it away.
Fantastic. Thank you all so much for your insights. It's been fantastic to hear your stories on the topic of stories today. So I work in digital health, and something that is constantly on my mind is how can we improve digital health and telemedicine to be more accessible to different forms of medicine, to different cultures. So in your opinions, what are some ways that digital health, telemedicine, what all the new technologies can improve to better incorporate Indigenous practices and traditional healing methods?
Okay, I'll start because this is my language. So we've done a fair amount around robotics, video conferencing, and even using remote ultrasound. So, you know, I talked about the birthing experiences, or even just getting ultrasounds in our communities. And we found out about some technology that was developed for the space station, actually, so that you could do diagnostic ultrasounds with the tech being, you know, thousands of miles away. So we were actually able to incorporate that. And the way that we did it was not me coming in and saying, okay, let's do this, but going to our communities, hearing what their stories were and trying to figure out ways that we could do this together. And so we explored these different things together. And in fact, sometimes I'd have to say, well, wait a minute, there's a few things that we have to do first before we can get this all going. But we did. And in fact, you know, I could show you a little clip of a film, or if you ever want to go to Northern Medical Services and look under resources, and there's a little video clip, or even on YouTube, looking for the Melody ultrasound. And it's of a woman who gets her ultrasound in her community, because normally it would take 3 days of travel to fly down and stay overnight and then get to the ultrasound and then go back. She would lose time from work, time away from her kids. It's just like, it's such a thing. And this way, she was in her community. She was able to be with the people that, like her family were there, people that spoke her language, because, you know, many of our people still speak their language. Greater than 65% in our areas speak their languages, their traditional languages, as their first language. So being able to have that is huge. The other thing that I really like about some of the technology that we've used and we've put out in our communities is that so often when, the way I explain it is, often when, you know, say a nurse at a nursing station is going to phone the doctor, that's the local doctor, and then the local doctor phones the specialist, and then it goes back and forth. And it's kind of like going through a translator. So there's this whole 5-minute conversation, and then the translator turns to you and says, no. And you sort of think, so was there something else going on? And when we're talking about mistrust, even that alone would make me think, did they really explain this? Like, what did they say? What are they thinking? What's going on? So when you have the ability to bring a specialist in, so we started with pediatrics actually, because we had a lot of kids that would run into problems. And so when we were able to connect the nurses with the pediatricians, suddenly it's the patient and the patient's family that are front and center talking directly. And the nurse or the doctor is off on the side listening and able to support, but it's the patient that can do that. And then the family can ask the questions that they want to ask. And it just changes the whole dynamic about who's talking to who and what's getting across. I usually tell people it's like the phone. It's not meant to replace in-person visits. We still need to be there on the ground. But there are times that we can't be there. It's just like with our family. We can't always be together, but we still phone each other and in between. And then when we can be there, we are there. So I think it's made a big difference in many of the communities. We've used it in a lot of different ways as well. When we had a really horrible tragedy happen in one of our communities, some of the people that were out and were in the intensive care unit for quite a long time. And one girl I think of in particular, she was, I think 12 or 13. She just wanted to get back home. And yet she was looking at 12 weeks of rehab still to try to get better and do all these different things. And so what we were able to do was put the technology, we call it a doc in the box, nurse in the purse, whoever happens to be using it, right in her grandma's home. And we taught her grandma how to use it in like 15 minutes. And so she was able to get her physiotherapy, the granddaughter, her physiotherapy, the occupational therapy, see her physician every day, right there in her grandmother's house. So I think there's a lot of things that we can do. The other thing that we started using it for wound care with nursing. We've used it now for physiotherapy. But the other thing I'd really love to see is connection to our kiteak, or our elders, our older people, but also to our traditional people. We are losing some of that in many ways, and it's hard for people to travel all over the place. So sometimes it's nice if they can connect or follow up in that way. And I think even the idea of sharing circles and sharing with different community members using technology can be absolutely amazing. During the pandemic, we had groups of, again, some of the key support people, which tends to be our kiteak in our community, our older people. And they were able to connect with, check up on people and make sure they were okay. And, using that FaceTime, like some of those elders, like I was laughing because they were in there and they were doing FaceTime and like, oh, don't you know how to use this? This is what you do. And so, technology is really taking off, I think, in a way that is unbelievable, but we can really harness that to the good, I think, if we use it in the right way. So I see it as a really strong positive, and I've got lots of examples of that.
On that comment, I recently read a literature review talking about how, especially in Saskatchewan, maternity services are becoming bunched in the cities, and healthcare is becoming a privilege of those who are in urban centers. And so these advancements allowing for the dissemination of those tools, of that knowledge across the province and across the country, I think is fantastic. Dr. Stott, I know it may be out of your wheelhouse, but do you have any comments on this?
No, I have a doctor of philosophy, not a doctor of medicine, so it's definitely out of my wheelhouse. But I just wanted to say thank you for creating space for these conversations, and it was lovely to meet you, Veronica, and Perry as well. And
awesome. Well, thank you so much. Yes, so a couple of these questions were made with Holly Graham and Cassie Cook also in mind. However, it is a Zoom day, as we've been saying all throughout, and so we got to live through the struggles. If there aren't any questions from the audience, I think it's safe to say we can move forward to our closing remarks. Awesome. Right on it. So the two things I'll note is we have a couple of things coming up. One of this is a medical herstory wide thing, whereas this event is kind of only in the purview of medical education. It's all hands on deck for the Feminist Health Research Conference at the end of this month. It's a 2-day event on August 28th and 29th, bringing together the leaders of feminist health. And so if you are interested in that, please come and join us. And secondly, this is something that we explore at all times of the year. You can, of course, publish your story with medical herstory, either through our periodicals or on our website as your medical herstory. As kind of has been a theme throughout this event, we deeply value storytelling and narrative medicine, and we want to give you the platform to share your own stories so that they can perhaps affect change and affect others. Next slide. Of course, I want to thank the lovely speakers today. Thank you for persevering through all of the Zoom issues that we may have had. I think it was an impactful event regardless. And I will just plug Medical Herstory once more. You can find us on social media at Medical Herstory across all platforms, and our website, medicalherstory.com. But with that, thank you so much. Have a restful weekend and a fantastic week next week. Thank you.
Thanks, everybody. Nice to meet you. And nice to meet you, Karen and Perry, and all the great people. Have a good day.